We're going to talk about chest tubes today. But before we get started on the chest tube, let's go a little bit over the anatomy just so we can understand it a little better. So I just want you to think about where your lungs are located in the body. The lungs are in the thoracic cavity. They're encased by the ribs on the sides and then the diaphragm on the bottom. So it's considered the intrathoracic area and it has its own pressure. With that being said, you have the lungs and there are two membranes. You have the parietal pleura and you have the visceral pleura. The parietal pleura covers the chest wall and the visceral pleura covers the outside of the lungs. And in that space between those two, there's lubricating fluid. So when you breathe, those two membranes can slide against each other. And that space is actually a potential space. It's called the pleural space. And sometimes if we get injured or we have lung issues, maybe someone has surgery, that pleural space can get disrupted. And what happens is you can get air in that space, that would be considered a pneumothorax. Blood in that space, considered a hemothorax. You could have fluid in that space, that would be considered a pleural effusion. And you can also, sometimes after surgery, there's concerns that that pleural space will be disrupted. And the reason why we're so concerned about the pleural space is because it naturally has a negative pressure of -4 millimeters of mercury. That's how we measure it. And what that means is that negative pressure helps keep those lungs inflated within our chest. So any disruption can really cause a lung to collapse. And that's where we get a chest tube. So sometimes a chest tube is necessary to help restore the natural negative pressure of the pleural space, to help the lungs heal, and to drain out any air, blood, or fluid. Chest tube generally, they can be different sizes, but they generally look like this. The part that goes inside the patient's chest usually is fenestrated, which means it has little holes so that whatever you need to drain can kind of drain around the opening of the tube also. So if you have a pneumothorax, most likely you will see, if you're dealing with a pneumothorax, you will see the chest tube usually between the second and third intercostal space on the anterior chest. And that's because air rises. So if you have atmospheric air in your chest and we need to kind of drain that air out to restore that negative pressure, we need that air is going to rise. So we'll put that chest tube up higher. If we're going to drain fluid or blood, that chest tube will be located lower in the chest because gravity will be pushing that fluid down and it will make it easier to drain. So this is what your chest tube looks like. And when they put the chest tube in, it's always important to note what number that chest tube is at because, what if the patient is moving around and somehow this starts migrating out? We want to be sure that that chest tube is staying in place. So best practice is each shift to tell the oncoming nurse, oh, the chest tube is at whatever number it's at, okay? Just to keep track of it. When you do have a chest tube in a patient's room, you should also always have an emergency kit. I think people a lot of times they make these kits and it's really important because it has Xeroform, it has 4x4, it has a Tegaderm, and it has tape. You also want to have clamps at the bedside just in case something happened and maybe the system itself became dislodged, you would want to be able to clamp it. This emergency chest tube kit will help you in case that tube comes out. You can immediately put that Xeroform on and cover it with a dressing until you get additional help. If for some reason the chest tube popped out and you were right there and you heard air gushing out of it though, at that point you would not want to immediately put a Xeroform gauze on it, a Xeroform, because it could lead to a tension pneumo. So if that were the case, you would want to just take gauze and tape it down on 3 sides and let the rest of the air escape. Obviously, you would be getting help at that point. Okay, so now on to the actual chest tube drainage system. So we usually use a dry suction chest drain here, and we'll explain the difference between dry and wet suction. But basically, when chest tubes were invented, there was a 3-bottle system. So this 3-bottle system is now encased in this canister. So the most important part of your chest tube is the water seal. And this is located in the compartment that says C above it. So if you're ever involved in having to set up a chest tube system, like they're putting in a chest tube and you are there, the first thing you would want to do is open the package, take this out. On the back, you have sterile saline. It is right here on the back of the system. It comes pre-packaged. Pull it off, open it. Before you even hook up the chest tube, put this water into here, because this water is going to show up in the water seal chamber, and normally it will be a blue color. On this one, you can't really see the color. But the whole point of the water seal is because originally when you had the 3-tube system, you would have the chest tube and you'd want air to escape if it was a pneumo, but you didn't want air to come back into the chest. So they said, if we submerge the end of the chest tube into water, that will help that air escape the chest and it will create a seal so no air can return to the chest. Because the thing is, if you have air returning to the chest, what's going to happen is it's going to either create a new pneumo or worsen one that is already there. So you always want to make sure your water seal chamber has 2 centimeters of water in it. Most people only keep a chest tube for maybe a couple days. If for some reason though you notice evaporation in the chest tube, in the water seal chamber, what you can do is take a syringe, fill it with sterile water, put a needle on the end, and then turn this around. Clean this off with alcohol. This is considered the grommet, this little circular gray area. And you can put water in until you reach that 2 centimeter mark. You need to keep it at 2 centimeters because it's the perfect amount of water to create that water seal in this. Okay, so you have your water seal. So then, when we originally had a 3-bottle system, people thought, well, what if we're trying to drain blood or fluid? Do we want that blood or fluid to drain into the water? No, we don't. We want to have a separate area for it. So that's where we have the collection area. So your collection starts over here. And this first, if you were looking directly at it, it would be the furthest area on the right. And then it fills from here. What you want to do is keep a running tally of the output each shift. So you can either denote it by marking right on the canister, or you can put a little piece of tape and put, the date and the time, just so that people know, okay, so on day shift they had 50 cc's out, and go from there. And then you want to document it. Lastly, we also have a suction area. That's the internal suction, because even though we have the chest tube and we have a water seal and we have a drainage area, we can't just rely on gravity. So we need to have a little internal suction. And when chest tubes were a 3-bottle system, this was the third part. And it was actually made of water. And that created some suction so that it would help with that negative pressure and help kind of pull some of that blood or air or fluid out. When you open this chest tube system, it is going to default on the suction area to -20. So you can leave it there unless the order says otherwise. If the order says put it to a different number, you can take this little rotary dial. This is a dry suction, which means we just control the suction through a little rotary dial on the side here. They do have wet suction systems still, but most places don't use them anymore. And that would just mean that the suction was controlled by like a column of water, but we don't do that anymore here. So we use the dry suction. So that's the difference between dry and wet suction. If you notice the order, if the order says patient chest tube to water seal, all that means is you're still going to keep the suction at whatever the default is, or unless they say otherwise, but you're just not going to hook it to wall suction. And so if you keep it to water seal, this little window here with the E next to it, this will just be a clear window. If the order says chest tube to wall suction, what you're going to do is take your chest tube tubing, put it here, connect it to the wall suction, and you don't want to connect it to the canister. You want to connect it directly to the metal part on the wall suction. And you're going to put the dial up to between 80 and 100. Okay? So the thing is it's confusing because if we already have internal suction, why would we be using wall suction? Well, the wall suction is not going to directly affect the patient's lungs. It's just going to add a little more negative pressure to help pull some of that drainage out. But this is the internal suction, so you're not going to hurt the patient's lungs if you accidentally put the wall suction up a little higher and then you realize, oh, I need to put it between 80 and 100. There's no damage done. It's not directly affecting the patient's lungs, okay? But that's about what you need to get a good suction for drainage purposes into the canister. One thing you want to make sure is not to tip over the canister. If you tip over the canister, it could look a little something like this. And this means like this was tipped because you see how this column's partially filled and this one and this one. So if that happens though, it's okay. It's just not ideal. We want to change the canister around if that happens. So something you can do, excuse me, you can clamp it at this point. This is really the only time you're going to use this clamp. You would take this off and clamp it just so that you're preventing any air from getting up into the patient, and then hook this onto a new canister, okay? And then you would want to make sure, obviously, you filled your water seal. Now, another thing about this is if you are hooked to wall suction, you're going to see the bellows. This is a little orange part that comes out and it reaches the triangle, which is called the delta line. So if it's on wall suction, you want to make sure your bellows are expanded. That just tells you that the wall suction is working properly. Things you want to assess with your patient, you would obviously want to make sure the patient respiratory status was okay. You would want to make sure if they were experiencing any distress that you're troubleshooting and seeing maybe somehow something got disconnected. It could be potentially very easy to disconnect if this is not reinforced. This is the part of the chest tube that goes into the canister that goes into the chest tube. It's a little Christmas tree, and a lot of times there's tape that reinforces it. Sometimes maybe the patient starts coughing and turning, and hopefully this doesn't pop off. If this did pop off, you would have your clamps at the bedside so you can pinch it off until you reattach. You also want to assess the dressing every day. You want to do daily dressing changes, and the daily dressing changes do not include the Xeroform. They just include the gauze, the Tegaderm, and the tape. And assess that site. You want to kind of feel around that site to see if you're feeling any crepitus. That's that air trapped under the skin. And if you are, you want to make sure if that's a new development, you're notifying the doctor. Something else you're going to keep an eye on is to see if there's an air leak. So an air leak will show up in the water seal section of this chest tube, and you'll read it if you're looking directly at it from right to left. So an air leak of a 1, that will be like consistent bubbling to 1, that's a mild air leak. If the bubbling is consistently going to 5, that's a high grade air leak. If this is a new development, you definitely want to call the provider and let them know. Sometimes they do expect a little bit of an air leak, especially, if you have a pneumothorax. The thing is that air, if you have a pneumo, is going to go right into this water and you'll see an occasional bubble. That's different than consistent bubbling, which indicates an air leak. But just keep the provider informed. They may be concerned, they may not be concerned. Let's see, something else. If you're going to transport the patient somewhere, make sure you have an order for transport. Make sure there's an order to take it off wall suction if it's connected to wall suction. And you always want to keep this below the level of the patient's chest. I mean, everything else, you're just going to kind of monitor it. They should have chest x-rays every day. And otherwise, if you kind of understand the science behind it, I think it makes it easier to take care of the tube properly. So just remember, as the nurse here, don't be too intimidated by this. Your most important section is the water seal chamber. As long as that is up to 2 centimeters, as long as everything is connected, you should be able to manage it just fine and monitor the output. Any questions or concerns, please reach out anytime. Thank you.